Thank you all for coming, for your interest in universal health care, and hopefully for your help in making it happen. I'm Susan Soberoff, you folks know that, with Finger Lakes for New York Health, I would like to dedicate tonight to Bernie Federley, who we lost last week. Many of you might know that had been an unrelenting champion for universal health care for single payer. And along with his partner, Rebecca Elgie, we are going to miss him. And I think the best way that we can remember him and honor him would be to just carry on this particular fight. And I also want you to know that this event, come sit down, come up front or something, is being co-sponsored by Tompkins County Progressives, by the Worker Center, and I was hoping somebody would be here from there. I don't see anybody, but also by Ithaca Health Alliance, the Ithaca Free Clinic, and Norbert McCluskey is in the back, and he'd be glad to talk to you and show you what he has information-wise. So please talk to them, talk to him. And now it's my very great pleasure and honor to introduce Dr. Oliver Fein. He has been a devoted advocate for healthcare justice and healthcare reform for all of his professional life. He's been a long-term member and past president of Physicians for a National Health Program, and now as the chair of the New York Metro branch of PNHP, he's helping to lead the movement towards passage of the New York Health Act. And even having done all those things, he's also managed to raise a beautiful family and hold down a day job. He is professor of clinical medicine and clinical healthcare policy and research at Weill Cornell Medicine. He's also associate dean of affiliations for them, and he's won numerous awards. For example, in 2015, he won the award for excellence from the American Public Health Association. And there's lots more. You folks will have to look him up to find out the details, because I'd like him to do the talking and for you folks also to do the talking tonight. Dr. Fein.
Thank you, Susan. Well, thank you all for coming out this evening. Susan asked me to focus on the New York Health Act, which is what we'll do this evening. Please, throughout the presentation, do not hesitate to raise your hand, ask a question, so that we can, in fact, really dissect this issue. I believe any physician that gives a talk should, in fact, give you disclosures. To my knowledge, I have no relevant financial relationships with commercial interests that would shape this talk. But as you heard, I am chair of the New York Metro chapter, the past president of Physicians for a National Health Program, a national advocacy program, nonprofit. But I have received absolutely no compensation from that organization. If anything, I've given money to it. So what are we going to do this evening? What I'd like to do is essentially go through this menu of items. First, really try to explicate what is in this thing called the New York Health Act. Then briefly talk about some of the challenges, questions that people have raised about it, and what are then some of the answers. Talk about a thing called the RAND study. This was a study that was released on August 1st of this year, looking at explicitly, the New York Health Act. and then at the end really say, well, what is to be done? So, looking at the New York Health Act and its basic principles, I think we would say it's this set of things. A single state fund covers every resident, a comprehensive set of benefits, no financial barriers to receiving services, no deductibles, no co-pays, funded through public funds, and a progressive payroll and non-payroll tax, and something that I would like to argue will cost us less. Let's see if this one works. Costs us less than we are spending now. So let's start with each of these points and see if we can dilate just a little bit more deeply into what's in this act. The comprehensive benefits are really many of the things listed on this list here. Primary and preventive care, inpatient and ambulatory care, prescription drugs. But then we're very explicit about there being coverage for dental, vision, and hearing care. Why? Because the Medicare program does not include coverage for those things. So someone who is interested in the New York Health Act should know that if they're on Medicare, they have the possibility of being covered for these. And then there's the issue of long-term care. And I have to say, in the original bill that has been passed now a number of times in our assembly, long-term care is mentioned, but it is kind of left out of the calculus. And it's said that it's going to be something that needs to be implemented in 2 years after the legislature assesses how it can be done. Well, I am pleased to tell you we've been pushing on this issue, and just last week, at least verbally, I got a commitment from Richard Gottfried, the author of this bill, the chair of the Health Committee, that in the new bill that they introduce in 2019, long-term care will be covered. So that's exciting. Free choice of doctor, nurse practitioner, and hospital, and then a kind of unique idea, a care coordinator. Everybody will get a care coordinator. This is not somebody who blocks your access to care the way it might happen in an HMO. No, this is someone that you can go to who knows about the system in your community and can advise you about how to, in fact, get appropriate care. We'll see how this works. You had a question about it.
Yeah, well, about what's on the list, mental health.
Yes, I should put that there, and addictions. My apologies that it's not there. Very, very good insight. And it is in most of the other slides that I have, but it should be on this list. Then the issue of eligibility. And you'll see that the bill says every resident of New York State is covered. This is probably the most radical thing that I'll say tonight. What do I mean by resident? Every undocumented person, for humanitarian reasons, for public health reasons, frankly, they need to be covered. And this bill says that if you can prove residency in the United States, indeed you are covered. No barriers due to sex, age, income, wealth, employment, or health status. No regressive insurance premiums. No payment at the time that you see the doctor or at the time that you are admitted or discharged from the hospital. And no deductibles and co-pays. You all know what deductibles are, eh? You'd be surprised how many medical students do not. It's a funny word when you think about it. What in the world is a deductible? Well, it's the amount of money that you have to pay out of pocket before your health insurance kicks in. And it therefore becomes a major, major barrier for some people, particularly if you have gone to an emergency room. And no copays. In other words, really guaranteed coverage. You know, Susan presents to the emergency room of a hospital. They do their wallet biopsy on her and find out she has no insurance. Oh, wow. What an opportunity. Let's sign you up for, you know, the New York State Health, right? It's your right. You're a resident of the state. Is there any private health insurance that would sign you up in the emergency room of a hospital? No way, right? How are providers reimbursed in the New York Health Act? Well, the idea here is clearly all providers should be paid in full by the New York Health Act with no charges to patients. No money that is collected at the time of a visit. Doctors at the initial part of this act would be paid fee for service, the way they are essentially today. Hospitals would be paid potentially by global budgets. Global budget is a situation in which the hospital gets a lump sum of money and all of its services should come out of that lump sum. What that means is that it can stop billing for, you know, that $20 Band-Aid or, you know, that $50 aspirin charge that they put down on the bill, you know, or, you know, all of those things. And that means that they don't have to have as large an administrative staff. Rates would be negotiated with provider organizations so that in terms of doctor reimbursement, there certainly would be a major consultation with MISNY, the Medical Society of the State of New York. And for hospitals, they would go to the New York Hospital Association and negotiate for rates. And it's possible in the future that new reimbursement methods may be developed, you know, to replace the fee-for-service way of reimbursing doctors. Why? Because fee-for-service really drives volume, you know, makes us frequently distrust the doctor, I would argue. Is she or he only, in fact, wanting me to do this procedure or get that CAT scan or do the radiation therapy in order to make money? I think we really want to get away from that. But we're not there yet, and that's something that might be a future direction for the New York Health Act. There should be progressive financing. What would happen in this single-payer approach is that there would be a trust fund into which all federal Medicare money, all Medicaid money, all child health insurance money, all of the Affordable Care Act funds would be placed. In addition to that, there would be a progressive graduated payroll tax, 80% of which would be paid by the employer, 20% would be the responsibility of the employee. A graduated tax on payroll, non-payroll income, such as investments. You know, frankly, a lot of people think that landlords, you know, in terms of rent, don't frequently report what they're getting, and in fact, certainly aren't doing it on a payroll basis, right? And New York Health would pay for the Part B and the Part D of Medicare, which is a premium component. So again, Medicare beneficiaries would get that. And indeed, the county share of Medicaid could be included here, so counties would not have to be taxing for that. Yes?
So would non-payroll income be income that a musician or an artist would,
If they did not report it
no, I mean, if
as
they
a-
do report.
as a payroll basis,
Well, it isn't really a payroll, is it? It's
no.
Yeah.
Self-employed.
It's a self-employed
It's self-employed.
situation. Yeah, I think those folks would in fact also be subject to this, essentially graduated tax on non-payroll income. And in fact, this is one model. By the way, one thing that is not in the legislation is precisely what the tax rates would be. So you have to understand that when we talk about this, for instance, this model comes from Gerald Friedman, an economist that did an analysis of it. There is a different taxing approach that the Rand Corporation made when they did their study. But what you see here that I think is interesting is Friedman said, up to $25,000 incomes, frankly, there would be no tax that a person would pay. Why is that? Well, think of Medicare, rather Medicaid, right? The program that we presently have. Those are people, again, who get coverage, but actually probably do not contribute in any way to the taxes to pay for that coverage. Medicare is for really poor people. And then there is a tax that comes into effect at $25,000, but for the individual, what happens is that you subtract the $25,000 out of their income, so that it is not this 9%, but it's more of a graduated percentage. And it goes up, as you can see again, that for someone who's over $200,000 and has a payroll of $200,000, they would be charged 16%. And this would also hold for people whose income is non-payroll. This was a chart that some students put together, that really tried to, illustrate what would happen in this kind of taxing. Again, this is not in the bill. Realize that. It needs to be advocated for. So the annual cost for an employer who employs somebody for less than $25,000 would be nothing. For that employee, it would be nothing. The employer, if they were paying insurance for those individuals, would save a substantial amount of money. The individual would also save money, including the deductible issues. The average employer savings for families, this is for individuals up to here, would be much higher, $13,000. For employees, family coverage would be $6,000 savings. So you get a sense from this of where, in fact, the savings come from, and you also get a sense of who are the people that are going to be paying, some more than they presently are. People with incomes of $100,000, $200,000, $400,000, just to give you a picture. Where does the money come from then, besides these taxes, so that we're not increasing the overall cost of healthcare in the United States? We're at a place now where we are roughly 18% of our gross domestic product, of all goods and services, are being consumed in the healthcare marketplace. That's double many other industrialized countries, which are somewhere down between 9, 10, 11%. Where does it come from? The general sense here is that, in fact, it's coming out of the administrative costs from insurers, hospitals, physician offices, and in general medical care administration. In Canada, it's just 2 cents compared to what is a huge package in the United States. And Gerald Friedman decided to apply this to the New York Health Act, and what you see here is his approach to where the savings were going to come from. Reduced insurance administrative costs, $28 billion a year. Reduced physician and hospital administrative costs, roughly $21 billion. Bulk purchasing of drugs and devices would save us essentially $16 billion, and reduced fraud about $5 billion. So he gets a total savings of 24.7%, or $71 billion just in New York State. Now, the problem is that there are increased costs, right? If you cover everybody, even those who are uninsured, your cost is going to go up, and he calculates that at $4 billion more than we presently are paying. And then if you eliminate the cost sharing, deductibles and co-payments, well, that's going to cost you more, right? $11 billion. And he has a very interesting proposal, because doctors so often complain that Medicaid doesn't pay us enough. Oh, and then some even say Medicare doesn't quite match what commercial insurance pays us. So he says, let's boost those up, Medicare and Medicaid fees, up to the commercial rate, and that's an $11 billion additional cost. So he gets an increase of $26 billion, but subtracts that from the 71, and he gets $45 billion net savings under this plan, or 15.56%. So just that you get a sense now, many people, economists have judged that this is a little bit too generous. And it should be said, the Rand Corporation, which actually does still say we make savings, that we will, with a single payer in New York State, come out better than if we stay with what we have. But they would make this much, much smaller. Yes?
Does that factor in covering vision, dental, and hearing?
Correct.
Where is that factored in there?
I don't know exactly where it is in Jerry's calculations. That's a good question. I should find out the answer. Yes?
Is this an annual saving or a one-time saving?
Well, I think this would be an annual saving. Good question about whether it's literally one-time saving or not. It would be perpetuated to the future, and actually Rand says it gets bigger. The savings get bigger over time. So you all know that we have a bill in the Assembly, 476, 4,736, put together by Richard Gottfried, and we have in the New York State Senate, Gustavo Rivera, very strong advocate for this. And we have 31 co-sponsors in the Senate. In order to, in fact, get this through the Senate, one needs at least 32 to get to be a majority. And the Republicans, unfortunately, have that number right now. Will they have it after November? Very interesting question. And you can see these are all the principles that we've talked about, so I'm not going to repeat them. But as you know, on June 1st, in the Assembly, this bill passed 2-1 in favor. So that's quite substantial. It was 87 to 38 in the Assembly. And as I said, 31 senators, but we need 32 votes in the Senate. If in fact that happens, then of course our big political question will be Governor Cuomo. We know the experience in California. They actually did pass a single-payer bill, but Arnold Schwarzenegger was the governor and vetoed it. Will Cuomo veto a bill passed by the state that guarantees universal coverage? I doubt it, particularly if he's interested in running for the presidency. We'll see. And just to give you a sense of the flavor here of what's happening around the country, what you see on this slide is essentially these states, the gray ones, are all the states that did not expand Medicaid up to 133% of the poverty level in the ACA, in the Affordable Care Act. You might say New York was considered one of the truly generous states. They're the green ones, right? Do you have any idea of where New York stood in terms of eligibility for Medicaid before the ACA? If 133% is the level now, what was it in 2009? It turns out it was about $9,500. It was less than the poverty level, probably close to 80% of the poverty level, even though we were considered one of the most generous states back then. So this has made a big difference in terms of people getting access to Medicaid. And then what you see here in these yellow dots are House members who are currently supporting single payer. And then what you see over here is, some kind of state initiative around single payer are these states that have these lines. Not necessarily as far along as New York State. I want to be very clear about that. But states that are considering that as an option. So, in summary about these things, the federal single payer looks unlikely, it seems, at this present time. And therefore, working on state single payer can be fairly meaningful. In the following ways, I just want to be clear when you look at it. Number one, it really does give something you can talk to your neighbor about, right? This is something concrete that's out there and you can answer questions about it. Number two, it gives you something to go and talk to your state legislator, either senator or assembly person, and educate them on this issue. What is the greatest source of Congress people in terms of careers? It's that they were state legislators before. And we have found, in fact, that some of the state legislators that were elected to Congress and learned about single payer because we went to them and talked about state single payer are, in fact, signing on to H.R. 676, the federal bill. Yes, there have been failed attempts. You've heard about those. I described California to you. Vermont very much started on the road toward a single payer. But I think ultimately the Governor Shumlin, who was a real advocate at the outset, wasn't sure that he could fiscally pull it off in terms of whether the state would be able to pay for it. It's kind of an interesting question. And you know, one of the factors that I think people haven't mentioned very much is, where do Vermonters get their medical care when they really require the expensive stuff? Cancer, heart transplants, things like that. Not New York, not Boston, Dartmouth, right across the border in New Hampshire. And I think Shumlin feared, frankly, that a lot of Vermont, you know, single payer money would be going over to New Hampshire. Then there was Colorado, who put this on, you know, as a resolution to be voted on about 2 years ago, if I'm correct, a year and a half ago. But what they did not calculate, they got enough, you know, signatures to get it on as a resolution. They did not calculate that the first thing that a Coloradoan would see when they were voting on this is that the tax rate would go up to 160, I think, or 180 billion dollars in the state. And it really frightened voters away from voting for the resolution. The need for federal waivers, and we'll talk about those in a moment. And you know, the other curious question is, we see a strong Republican emphasis on block granting Medicaid. Yes, we have resisted that on a national level and should continue to resist it, to be honest, because the problem is that, you know, it doesn't deal with the fact that if you had an increased number of people who needed Medicaid, the country, for instance, goes into a 2008 downturn, right? Unemployment goes up. You know, a lot of people become eligible for Medicaid. Oh, you're going to get the same number of dollars, you know, that you got before. Block granting is a disaster, no question. But what we're talking about with, you know, the New York Health Act is the possibility of some degree of block granting Medicaid to New York. And maybe that is sellable, frankly, to our present administration. So here are, you know, some of the questions that frequently people ask about the New York Health Act. You know, what's going to happen with all of those people who deal with insurance? You know, the hospital workers who are dealing with coding and billing, and frankly, the persons in the physician's office that have to deal with, you know, denial of claims and prior authorizations and things like that, which are really prevalent in private health insurance. Yes, we're going to have a lot of displaced workers. And here's some estimate about the number of those. It is estimated that 300,000 employed administrative people, billers and so forth, by doctors and hospitals, process insurance billing.
In New York State?
In New York State alone, yes. Quite a large number, right? And 26,000 are employed by insurance companies. Here again, some of us have raised the question, how much of what the insurance company does is actually offshored? And a lot of it is done in India, right, or other places. But we don't know that exact data at this point. So let's assume, you know, that doctors and hospitals still need some administrative staff, right? So one half of those become, employed by the providers rather than being laid off. But the insurance companies are probably going to yield all of the people that are doing billing and collections. So everyone in the New York Health Act would get 2 years of unemployment. That's in the billing, that's in the bill. And some retraining, some, to work in healthcare, maybe becoming a care coordinator, doing those kinds of things. And Rand estimates that there would be 200,000 new jobs from companies that will move, into New York State, because they want to have the benefit of a state insurance. And in addition, companies that no longer are putting as much money into health insurance will have extra revenue, which will probably, hopefully, go into people's paychecks. So any questions about that issue? Yes?
Maybe this is clear, but is it anticipated that states that adopt a plan like this would just fairly put an end to the insurance industry?
Well, think about it for a moment. I mean, it's not that the state, and we'll get to this under the ERISA provisions, but think about it. Here you are, you're an employer, you have 25,000 workers, you're paying insurance for them, usually 80% of it. You could continue under the New York Health Act. There's no reason you couldn't, but you're also paying taxes on a progressive basis for the same coverage. Would you be foolish enough to continue to provide private health insurance? Well, there may be some places that do that, but most will not, I think. They will, in fact, say, we're going to shift to the state program. So here we have federal waivers. This is the notion that if, in fact, Medicare is all of its funds are going to be put into this trust fund that the state controls, and that all of the Medicaid money goes into this trust fund that the state controls, doesn't, in fact, somebody in CMS, the Centers for Medicare and Medicaid Services, have to approve that in some way? And will they do that under this administration? Well, similar to global budgeting of hospitals, you know that that's being done right now in the state of Maryland because, in fact, CMS does do demonstration projects. So it might, in fact, view New York doing this as an interesting demonstration project. Let's show that it fails, might be their attitude. Right? Yeah. So who knows? They've agreed to do this. What happens now in the state of Maryland is that every hospital, they started with what was essentially a hospital single payer approach. Every hospital gets reimbursed the same amount from private insurance, from Medicare, from Medicaid. And now what they've decided to do is move into a situation where a hospital will get a lump sum of money from each of those payers based on what those payers paid last year, essentially. And then there's the whole notion of Medicare being a wraparound, provide an extra payment to providers to cover the deductibles, the co-payments, and so on, that are implicit in the traditional Medicare program. Okay? But another idea that has been proposed is, well, why not make New York Health a Medicare Advantage plan? Just like some of the existing Medicare Advantage plans that are run by private health insurance companies. Then we wouldn't have to ask CMS for a waiver. We would just say, oh, we have become, the Medicare Advantage plan for New York State. And this idea has been talked about a lot and may be a way to move. This would be, dealing with something that would be modeled on some capitated payments to private insurers, essentially, which is Medicare Advantage, right? And replace the fee-for-service program. It would resemble a program that already exists, again, as a demonstration project by Medicare, by CMS, Medicare and Medicaid, in what are called the duals program or the FIDA program. And then there's Medicaid and CHIP. We described the block granting of those programs as being a possible way to move ahead. And yes, indeed, CMS has granted, Rhode Island a global funding waiver for Medicaid, rather. So there are a variety of approaches to this issue of waivers. It's not, I think, a fatal flaw to the New York Health Act. Yes?
Can you describe a little bit about how this trust fund would work?
Would work?
Yeah, how, within the state, who's going to be over it, who's going to manage it, all that stuff. Is that explicit in the bill itself, or will this be run under the state's comptroller office, or how?
That's a good question. I believe that there is a proposal within the bill that describes the board that would be responsible for running this. And the governor has a number of members of that board. The legislature does, the hospital association does, MISNY does. I don't know the explicit numbers off the top of my head.
I think it's under the Commissioner of Health.
But it's under the Commissioner of Health overall, yes. What about wait times? This is another issue that a lot of people have raised, You give everybody insurance, you don't charge them anything when they go to the doctor. We're just going to get overutilization, right? Everybody's going to go, and then the only way the system will handle that is by, getting, reducing, or rather, dealing with wait times, longer times. One thing to say is that under private health insurance, we have a whole program that does also have a lot of wait times built into it through provider networks. You can't go, to Memorial Sloan Kettering Cancer Center, particularly in some of the Medicare Advantage plans, because they're not in your, network. But, frankly, there would be no discrimination against Medicaid and Medicare patients because they have the same rates. Now, in some parts of the state, we clearly find this to be the case, that Medicaid patients don't have access, to every doctor. Medicare, many physicians have said that they're not going to take Medicare. So this would eliminate that problem. There would be reduced paperwork for the doctors, and what that would do is liberate some time that doctors can spend with patients. And there would be kind of an ability to absorb the increased utilization. And we'd be able to manage a little bit more carefully the supply of doctors and hospitals, particularly in rural areas and particularly in urban poor areas. So this is a whole phenomenon. People have looked at this Historically, when the Medicare program was passed, in 1965, within 5 months, over 16 million new people were enrolled in that program. Was there a huge waiting list? No. Doctors accommodated those patients in their practices, frankly. They might have even been delighted to take them. We saw doctor incomes actually go up substantially after Medicare was passed. We would have a mechanism for dealing with a problem if waitlisting became a big problem. Yes?
Should be chasing the important other element of the wait time. Right now, if you need an expensive treatment, then the doctor needs to ask the insurance
To get
company.
prior approval.
Yeah, and you sit there waiting and waiting and waiting, and some people wait till the grave until the administrator, somebody behind the desk signed up rather than the
Yeah.
doctor taking care of you. So that's,
Well, I can tell you that's a major problem for me in my practice, that I can't sometimes get the insurance company to respond, in terms of prior approval for a procedure or what have you. Yeah. And then the fourth issue is this ERISA problem. Everyone's heard of ERISA, haha. This is the Employee Retirement Income Security Act, which was passed back in 1974, and it essentially dealt with the issue of uniformity of employer-provided pension and health benefits. And the law essentially says a state cannot establish laws that impact on these employer frequently self-funded plans. But the New York Health Act doesn't violate the ERISA provisions, just as I described it to someone who had the question over here. The employer can continue to offer their plan. But they will also have to pay a tax. And we believe that what will happen is that most employers will go, essentially and eliminate their health insurance programs. So it does not regulate the employer-provided benefits. The employers must pay a statewide tax for health, but they can maintain, limit, or eliminate existing programs. All right, let's turn to the RAND study, and this is a little bit wonky, and let's see if we can get through it. The major findings of the RAND study are that, number one, New York can afford the New York Health Act. That's important because, frankly, the opposition to the New York Health Act keeps saying it'll make the state go broke. It just is too expensive. It won't, in fact, work. So that was a significant thing, and one that I must admit we did not anticipate. We worried a lot when the New York Health Foundation wanted to get one of the kind of mainstream, consulting groups to evaluate the plan, that they might in fact get a group that would use a methodology that would say, we're going to lose money here. That the RAND group did not find that, I think, is quite significant. They're not Jerry Friedman. Everyone can be insured for comprehensive care at a cost of no more than we are presently spending. It's kind of amplifying that. RAND's base case shows only minimal savings, but includes long-term care. Again, one of the first studies that really does that. So that, to us, is very significant. And, yes, the New York Health Act would result in $139 billion of new taxes. That's a lot of money. gets up there into a high percentage of what the entire state budget is already. But it's less than what people pay today. And let's see if we can illustrate that some further. So within that study, the RAND study, here is the sources of health insurance in New York State. I thought this was really interesting. So 9.4 million New Yorkers get their health insurance through employment-based private health insurance. Another 1.8 million New Yorkers get individual non-group health insurance. There are 4,300,000 Medicaid, Essential Plan, and CHIP patients. Isn't that amazing? You didn't realize that, at least. Medicare, we've got about 2.4 million Medicare beneficiaries. Dual Medicaid and Medicare, an additional 1 million people. And we still have, in spite of the ACA, 1.2 million uninsured people, for a total population of roughly 20 million people. So what are the sources of healthcare funding in New York State? RAND projected these fundings all out to 2022. They felt that, that might be the time at which the New York Health Act actually was implemented, and so they wanted to give you a sense of what was going to happen. So in terms of payments, again, the fascinating thing is that the federal government is the largest source of healthcare and reimbursement in the state. If you can consider a single entity, it's $120 billion in Medicare, Medicaid, CHIP, the ACA supplemental plan, things of that sort. Employer-based insurance is next, $84.8 billion. The individual non-group market is $10 billion. And this figure is a little bit more because we felt the RAND group underestimated this. State government, through states and counties, contribute $34 billion to the Medicaid budget. And then miscellaneous other payments, $27 billion. And then you and I are all paying out of pocket that co-payment, that deductible of $33.5 billion for a total health budget in the state of $311 billion. So what we decided to do was to, yes?
I really wish on that previous slide, they hadn't lumped together state and county. Because the state can use income taxes, state income taxes.
The counties can.
Counties can't.
Except for New York City.
And Yonkers, I believe.
We have an income
Yeah.
tax in New York City.
It's based on the property tax out here.
That's right.
And I would really like to see what that proportion is.
Yeah. And the problem is it's been changing a little bit, but RAND doesn't deal with that problem, unfortunately, as I understand it at least.
I think it was 50-50 for quite a while.
Well, that is the way it has been.
60 and
Yeah,
election, yeah.
right. That it was 50-50, federal government, 25% state, 25% county in New York. Now, interestingly, you go to Mississippi, what's it there? 80% federal, 20% state government. Why? Because Mississippi is judged to be an overall low-income state, whereas New York is judged to be a wealthy state. And so it was worked out that the proportions, those states that are considered wealthier would pay, the feds would pay less and the state would pay more. Okay. So here's the original RAND model. This is their estimate of the status quo. Again, you get to that 311 billion down here, total expenditures. In terms of healthcare services, 255 billion. Of those, 163 billion are Medicare, 48 billion prescription drugs, non-durables, 6 billion long-term care, this is where they incorporated it, 38 billion. And then the total administrative costs out of this was $55.7 billion, and health plan administration consumes a large portion of that, 28 billion. Provider administration, 26 billion. State financial administration, not very large. Employer health benefit administration, not that large. And you get this total number of 311 billion. So then they go ahead and they say, well, this is what we think the New York Health Act will do. This is their numbers, okay? By the way, this is not in the bill itself, again, remember. So they say, well, if you give people more access to care, cover the uninsured presently, get rid of deductibles and co-payments, more people are going to use care, so it's going to go up to $173 billion. They took no decline on prescription drugs. They said there are going to be more prescription drugs, right? Because there are more people using the system. Non-durables, for some reason, they didn't increase, and long-term care, they kept at the same number. Then when it came to administration, yes, there will be, some degree of saving. Much of that is going to be from health plan administration, very little from provider administration, and we think that was probably not accurate. And then no questions about the state and employer. So they get the New York Health Act coming in at $308.9 billion. And that gives you that modest, essentially $2 billion of savings. Okay, and allows them to say, and us to say, that you could put in the New York Health Act and actually save some money, not a lot. Okay. So we decided, let's see if we can compare that, essentially with our estimates, helped by Gerald Friedman, but not explicitly only Gerald Friedman. And what we came to is, yes, we'll accept that there's more utilization, there's going to be more health care. But we think that with 20 million people in one plan, it would be a very powerful negotiator with the pharmaceutical industry. And the pharmaceutical industry will give us lower prices. We can see that looking at the province of Ontario in Canada, which has been able to get a substantial decline in prescription drug costs. We left the long-term care in place.
Why wouldn't that go up also, though? Because now all these people who would never have afforded long-term care will now get long-term care.
Well, I think basically this is the big difficulty. No one has a terribly good way of estimating what the cost of long-term care is going to be. And so we said, if Rand has a methodology that they've used, presumably, and we don't have big questions about the methodology they use to calculate long-term care, let's go ahead and just accept their long-term care amount. Okay, I mean, when it comes to administration, however, we felt that there were much larger savings than Rand projects, and that those were heavily in the area of health plan administration, from 28 down to 8 billion. In provider administration, we really thought they hadn't calculated accurately how much, in fact, doctors' offices and hospitals would, not have as much administrative costs. So it goes from 26 to 9, and then these two stay the same. So we get a savings of a total cost of the system of 272, and a savings of $39 billion. Okay, yes?
I'm curious why the employer health benefit administration wouldn't go down to nearly zero. I know that's a small piece of the total cost, but that seems like a real selling point of this to businesses, that they would no longer have to spend money on administering health benefit plans for their employees. They'd just be paying this tax.
Yeah, that assumes that what we're talking about here is only private health insurance. Okay, the problem is that Medicare and Medicaid also have an administrative cost. It's much lower. Rand estimated that cost to be 6%. We know that the Medicare program has an administrative cost of roughly 2%. But we decided, I think, ultimately to accept their 6% number for Medicare and Medicaid, and we're able to get a lower administrative cost overall. So it's not just private insurance that gets reduced. If you stop having to bill, Medicare for Band-Aids, for, various items that are involved that we see being billed now, right, for aspirin and things like that, just overbilling for them. That happens to Medicare as well. Okay, so what happens here is that we calculate that there'll be some savings, not only from private health insurance. It doesn't go to zero administrative costs. There'll be some still there. 8.3 billion. Am I right? Yeah, health plan administration. And then finally, what we did is what I just described to you with the RAND with modifications. Because, by the way, some of the things that we put in there, they suggested might be put in there. So it wasn't just us. It was, they said there are alternatives, and we put the alternatives in. Ignore these numbers up here. Unfortunately, they aren't. It's 2022, okay? No billion, no dollar sign, right? And Friedman made his estimate on 2019 dollars, but Rand again was 22. And what you see here again is the cost of covering the uninsured and the elimination of cost sharing. Friedman made a larger calculation, $2 billion more dollars there. Enhanced physician fees, Friedman estimated it would be higher than what Rand put into their calculations in the modified plan. Okay, as you can see here, they didn't calculate that at all in their original plan. And so the total increased costs in the Rand modified plan, 25.9, in the Friedman plan, 26, not too different, in the Rand amount here, 17 billion. But it's again in the savings that we see much bigger changes, reduced administrative costs. Friedman would estimate that those would be 28.6 billion. reduce provider costs, 20 billion. The ability to purchase drugs, would give us savings of essentially 16 billion. And here in the original ran very little, in terms of savings for drugs, but not bad amount in the modified. And so what you see here is a situation in which Rand gets, again, a very low amount of savings, 0.7%, that $2 billion that I described earlier, whereas Friedman got his 15.6 billion percent lower, $45 billion. And in the modified Rand, we got something that's around 9%, or 29 billion. So all of this is, as I say, a little wonky, but it gives you a sense that one can, in fact, deal with these things. And the conclusion, I think, just has to be, that the New York Health Act creates a publicly funded single-payer plan, that it covers all residents of New York State, improves benefits and includes long-term care, eliminates co-pays and deductibles, and it improves benefits, including mental health. Yes, thank you for bringing that up. Eliminates co-pays and deductibles, pays providers at the present private rates, yet doing all of those things, it costs less than private health insurance premiums plus the ACA premium subsidies to private insurance, plus patients' out-of-pocket expenses, plus Medicare, Medicaid, Child Health Plus. We save some money if in fact we go to a state single-payer program. But it will increase taxes, no question about that. But presumably taxes that we hope will be very progressive. But that, the tax increase, the way that will be designed is not presently in the legislation, other than to say that it is going to be, in fact, a situation in which it will be progressive, both for the employer and for the employee. So what should we be doing? Well, yes, you all should learn more. Really go to our website, both the local one, which we're still working on. It isn't the greatest website, but it does give you a lot of information about New York Health. And go to the national website if you're interested in looking at the federal proposal. Secondly, I'd like to pass out to you the 10,000 docs petition, essentially. We're trying to get over 10,000 docs to sign that they would favor the New York Health Plan. But none of you are doctors. Take this to your doctor the next time you go and say, look, I'm a single payer advocate, why don't you sign this? And leave it with them, and hopefully we'll see some action. So let me pass these out. We'll get this group here. And this group over there. Okay. Thirdly, join, that the major proponent of this is the Campaign for New York Health. The reason that they're different from Physicians for a National Health Program is that they are a 501c4, which allows them to, in fact, be much more politically active, to actually support individual, candidates, to really get into the weeds here of the issues. And then really do visit your local legislators. Come to Albany. We'd love to have you join us. There will be a lobby day again, probably end of May, early June, when we feel we can visit most legislators. And here you'll see the white coat presence that we had this past June when we visited the legislature. You'll see here a very interesting group of both medical students and doctors who went and spoke with their legislator about the New York Health Act. You can do that as a 501c3. All that you can't do is say, you know, I'm going to go out and get you defeated, or I'm going to go out and be sure that you get elected. That we can't do. We can't go with the individual legislator. Yes?
I'd like to suggest, just besides visiting your legislators, also the candidates that are running against them.
Of course,
Because
of course.
right now I'm hearing, I listened to Channel 12, and it's really a nasty campaign back and forth, Claudia Tenney, and I forget his name. When the Tenney ads say, oh, it's going to cost us $130,000 more in taxes, because they don't say anything about the savings.
But they don't say anything like, we are presently spending $141 billion. You know, and this bill would in fact allow us to go save at least $2 billion, and the group that says this is in fact a very mainstream conservative, you know, analyst, you know, the Rand Corporation. And then finally, I will give you some references here. But the other thing I would like to do at this point, I really have appreciated the efforts that Dr. Susan Soberoff has made to bring me here and to bring you here. And so I wanted to give her something. This is bold self-promotion.
Thank you. This is his daughter, who wrote this book. Thank you, Alan, very much.
This is, I think, a great book, of course, biased. Fear City is about the 1970s fiscal crisis in New York City. You know, something that I think may actually be on the horizon for us again in this country. And it's really, I think, a fun read. So, any other questions, comments?
When you say we're already paying, are you putting together employers and whatever each of us as citizens are paying out of pocket?
That's
for
right.
Premium and our deductibles and all of that? When
Yeah.
you say we're already paying.
That's right. If you recall that slide, where is it that gets us? I think this status quo. Well, it doesn't.
I'll take your answer, it's fine. I mean, my eyes get bleary after a while looking at all those numbers, so I just need an
see.
answer. Thank you.
Yeah, no, it definitely includes, you know, the amount that is being paid out of pocket, that's being paid for private insurance. So probably does not, the reason this number isn't there is that it takes out the Medicare component because you've paid for that already through your taxes. One of the real problems with Medicare, you all know what, in terms of taxing, what's the problem?
It's not progressive.
It's not progressive. How much is it? Anyone have an idea? It's 1.45% out of everybody's income up to $120,000, after which, this may have been actually modified by Obama, but after which, before, you didn't pay anything. The high income people didn't even have to pay more than, you know, the 1.45%. And then your employer is putting in 1.45%, so that the total amount is 3% roughly, 2.9. That you're paying but it's a flat tax, really regressive, because in fact poor people with low incomes have to pay the same amount as people with high incomes. Yes.
And to this lady's question on the employer side, I can report it from Transonic System. We're a company with some 20 million annual revenue. We're right now paying 10% of all of our revenue
In health insurance.
in health insurance. That would be a benefit to us to pay that money, or under the plan, it's probably 8% of it, 70%. Pay it in some form of other taxes. Right now, it's taxes that has profit for insurance companies, and if we can do directly to a single payer plan and have it run without all of the, we're saving money. We don't have to hire one administrator to run our private insurance plan. It's good
Oh,
for
great.
business. It's good for business.
Right, and there are a number of businesses that have felt that way. I would advise, there is a movie called Fix It that was put together by a Pennsylvania, not literally small business, something like probably your size business, but who really feels, he could do so much better if he didn't have the health insurance component to his expenses. Yes, in the back.
Have there been any additional cost-saving studies done that would relate to the savings in medical care that would come from having everyone have access to medical care, early intervention, and we could take it even farther, lost time from work and so forth? All of that, I would think, would be significantly reduced once everyone had access to health care and they got the flu treated with a $10 bottle of antibiotics, as opposed to having to spend a week in intensive care getting intravenous antibiotics.
In terms of studies, I would say that there are attempts to try to get at that question. The simplest thing is to look internationally and compare countries that have single payer, essentially, or universal coverage. And what you find is that they really have a better life expectancy than we have in the United States, right? Our infant mortality rate is sometimes 3, 4, 5 times what it is in these countries that have universal coverage. Our maternal mortality rate, I couldn't believe this, but mothers dying, in pregnancy is, again, probably 3 to 4 times what it is in other industrialized countries. So you can look at those things and say, yeah, I think that there is a way in which this impacts. There is an attempt to try to show that in the United States, but I'm not sure I can cite a specific study for you right tonight. Yes?
I just wondered, are the medical costs for veterans included in these figures? I mean, aren't veterans under basically a federal policy?
Yes. This is, you'll notice that we haven't mentioned veterans, and to my knowledge, the judgment has been not to include veterans in the New York Health Act at the outset. And that largely has to do with the fact that the feeling is that the Veterans Administration, in spite of all of the negative things you may have heard, actually does a remarkably good job.
Isn't that a sort of a single payer?
Oh, what it is actually a situation that is very similar to the UK, to Denmark, to Sweden. It's a national health service, right? What does that mean? It means that the hospitals are all owned by one entity, namely the government, and the doctors are literally on salary, are employed by that entity, the federal government. You'll learn here, we're not talking about a national health service, right? We're talking about publicly funded healthcare and privately delivered healthcare. Delivered essentially, by doctors and hospitals that are not owned by government and not salaried by government. Okay, makes a big difference. From a doctor point of view, just so that you have a sense, one of the aspects of this, is that you can, under this kind of approach, decide how much you want to do practice. You get a little bit older and maybe you want to reduce the number of days in practice and so on. That's much harder to do in a national health service. Yes?
I'm really pleasantly surprised at this progress and deeply impressed. But I would just ask a quick question, I think it's wondered about. Fee for service, is that a great idea? Obamacare had taken steps to get us away from that. Do you have a position or a position?
Yeah, no, I think, frankly, fee for service has this difficulty. On the one level, it leads to, a situation where to make more money, you do more procedures and you see more patients and so on and so forth. On the other level, it, in fact, ends up with patients not trusting you and not trusting what you're recommending for them. So yes, I think it would be good to transform our system away from fee-for-service. But I think the judgment in the New York Health Act was, let's take one giant step and then, in fact, begin to, once we've done that, begin to really deal with this kind of problem, the fee-for-service problem. Yeah. Yes.
It's all wonderful and we're so close. We are so close and I think it is going to happen very soon. My concern is with access and wait times. And you mentioned Memorial Sloan Kettering. If we all had the same problem, we all wanted to go there, we wouldn't be able to do it as soon as that act passed. And I'm most concerned about dental care because that is something that is so lacking in this country in terms of people's access to that. And there's going to be such a huge need in this state if this does pass, and we won't have enough dentists. And is that being considered?
Well, I think, as I mentioned, how to describe it? Again, if doctors and dentists don't have to deal with the paperwork around delivering health care, it is very possible that what will happen is they'll have more time. The estimates for at least a primary care doctor now is that 20% of our time we're dealing with billing, collections, and chart notes that satisfy the insurer, what people call meaningful use. So there might be, in fact, more time, on the dentist schedule, more time on the doctor's schedule to see more patients. Okay. I can see you're skeptical, but that's at least one answer to that question. Secondly, it would seem to me the other interesting thing is one could really talk, about how to deal with the supply problem. And we presently don't have a good way of dealing with that under private health insurance. So, yes.
So, under this kind of care, all patients would be considered equal. Like right now, dentists can say that they're not going to accept Medicaid patients.
Right.
But if we had something like this, everybody would be equal in terms of what they could get.
Let's be clear that what this would guarantee, it seems to me, is financial access. But there are still very strong biases within the medical community. So, for instance, if you didn't want, in New York City, a lot of African Americans in your practice, you would decide to locate your practice probably on the Upper East Side of Manhattan, right? So, will this cure some of the biases that exist in the system? I hesitate to say that's entirely true, but it's kind of a very important first step, because without it, I don't think we will be able to address other kinds of biases that exist. Yes?
I would think that more people would go into to medical service would become doctors. I've just heard it from some young people that they just can't face all the administrative paperwork, and that's not why they want to be doctors, and so they aren't doctors. But if this administrative burden is really eliminated or lifted, I just think we may have more doctors.
Yeah, but one has to say, I don't think the reason we have a shortage of doctors, if we do, and I think we do a little bit, is not so much that people don't want to become doctors, but in fact, we have a limited number of medical schools and places in medical school, a very high debt rate for people who graduate from medical school. It's up now to about $180,000 on average. And that's just the kind of thing that doesn't induce people to go into medicine, you're right. But we still get, at a place like Cornell, 6,000 applicants each year for 106 places. And let me tell you, they are amazing applicants with grade point averages of 3.87. I couldn't believe, we just went through this with our admissions office. So there are some real problems, yes, but I'm not sure in terms of the numbers of doctors. That's something, again, that we ought to have a little bit more control over, federally and statewide. Yes?
Hi, so we've been talking a lot about the cost, which is absolutely essential to getting anything like this through, but we haven't really talked about the range of things that we'd be getting for that cost. And what I'm speaking of is Ithaca, alternative care like chiropractic, acupuncture, dietary management, which is key for diabetics, things that don't fall under the MD or
You're very right. At this point, I don't know that the New York Health Act does actually deal with that dimension of the problem. We have a number of members of our board that are working with Dick Gottfried to talk about alternative treatments and alternative approaches. So that is important, but I'm not sure it's in the act yet.
Yeah, I forget the New York plan that's one step above Medicaid. What is it? The essential plan.
The essential plan.
Even that one has gym membership is covered because it's so well proven as a preventative strategy.
Right.
But yet it's not being discussed as part of this.
I don't believe it is, but we're trying to stimulate that discussion. Now, Medicare Advantage plans frequently offer free gym membership. So I said, that's great. My patients can use that. And then I thought about, how about that patient with congestive heart failure? Or my patient with cancer? Or, my patient with rheumatoid arthritis? These are people that are not going to go to a Medicare Advantage plan because of a free gym membership. It's an explicit way for those companies to attract the well and leave the sick in the traditional Medicare program.
Right, though I'm just using that as an
Yeah.
example of
No.
preventative strategies.
Yeah, no, exactly. And I would keep pushing on that as an issue. I think we should be incorporating that. Yes?
Can you characterize which stakeholders in the healthcare industry are in support of this and which entities are opposed?
Yeah. Well, let me give you a sense of this because it really was interesting to me. I was up on, lobby day for the New York Health Act, and we went into a senator's office. We didn't meet with the senator, but we met with one of his top staff people, and he said, did you realize 54% of New Yorkers do not want the New York Health Act? I said, what do you mean? Oh, he said, just last night we got the data from the New York Business Council. So, in fact, the opposition is beginning to organize. You're going to see a lot more of it. Yes, I think initially it has been the business community and the insurance industry, but I think there is also going to be opposition within the medical community, particularly, I would argue, by those large systems. I worry about my own, the New York Presbyterian healthcare system. New York City is just proliferating with systems, and they're not going to like the New York Health Act, I think. The state medical society is, historically, the medical societies have been very opposed to single payer. Now, in 1965, the AMA spent over $5 million, which in those days was a lot of money, to defeat the Medicare program. Fortunately, they failed. Right? But I think that the change now is that the president of the New York State Medical Society, present one, and the president-elect, just last week met with Dick Godfrey to talk about the New York Health Act. And I think there's going to be, within organized medicine, some increased interest, in figuring out how what their stand is going to be. Will they oppose this? And then finally, the other groups that I think we can predict will have problems with this are those very high-paid specialists. As a group, who are they? Orthopedists, neurosurgeons, cardiac surgeons, some of whom, again, are earning huge amounts of money. And I think under the New York Health Act, we'll probably not be able to quite make that kind of killing. So I think we think that this shows that to some degree the act is serious. I mean, up until this time, I don't know if you realize it, the New York Times has not written one single article on the New York Health Act. Right? I think you'll see in the next, 4 or 5 months that they will. And that means that the opposition is beginning to speak more loudly. The New York Times said, well, that'll never happen. What we think the RAND study suggests, at least, is that one of the major, reasons for opposing the New York Health Act was it's not economically feasible. Well, the new thing that you're going to see is it's not politically feasible. You're going to hear that. And I think we've moved things along so that we're not quite in the same place that we have been. But the opposition is going to rise, and the more it rises, the more you should say we have been effective. Yeah.
A couple of comments. I would add that I think another faction that would really oppose this would be the pharmaceutical industry and the medical device manufacturers.
You bet.
Because
You bet.
with a unified act like this, there would be clout to negotiate
Prices.
bulk purchasing and prices, like the way that the VA does. And, you know, the pharmaceutical industry and medical device manufacturers have extremely deep pockets. So when they want to lobby against something and scare people, they've got a lot of money to do it.
Yeah.
So I don't think we should underestimate their.
Very,
their
very
strength.
good
Yeah.
point. And so that's really, I think, an important thing to realize. They are a formidable force, and they're going to oppose this bill.
The other comment I just wanted to make, because I think this happens somewhat in Canada, is that, like, right now, say in Tompkins County, there's a lot of people who are unhappy with their health care. For example, it's extremely difficult to access any psychiatric care, regardless of what your insurance is. But people don't really even know who to be upset with because it's so diffuse. They don't know if they're upset with their insurance company or the doctor. When you have like a single payer system like this, whether it's justified or not, people then blame that. Like, so if this passed and people had the same trouble seeing a psychiatrist in Tompkins County that they do now, they'd be like, oh, it's because of the New York Health Act. And I think they see that in Canada, that even though, you know, in general, the single payer system in Canada is quite popular. Certainly, if you ask Canadians whether they'd rather have our system, they definitely would not. But people tend to channel anything they're unhappy about within the healthcare system tends to kind of then get focused on that. So it's just a comment. I don't know if there's anything we can do about it, but.
Well, there is the realization, though, that if in fact your healthcare system doesn't have, you know, the private insurers and so on and so, you have at least a political way to hold, you know, the system accountable.
Mm-hmm.
And that you don't have, you know, in the present situation.
And more of a shared interest in having a good
That's
system
right.
for everybody.
That's
so
right.
Everybody's in it.
Yeah.
Could I just make an announcement? I think probably everybody in this room is aware of Amanda Pritchett in the race against Tom. She's a very strong supporter of New York. There's some flyers.
He's talking about.
Yes, I know. He's talking about Amanda. I'm scheduled to meet with her right after this meeting. So, hopefully, that's, I think, certainly an important political fact. Yes?
When this passes, what do you see as the implementation timeline?
That's a very
Is this
good-
1 year, a 2 year, a 3 year?
Very good question.
Is this?
I think we would argue it would be really important that the implementation time be short, that it be 1 year if possible. And the reason being that there'll be all sorts of ways in which it will try to be compromised if we wait longer. You know, again, think of the Medicare program. It was literally implemented within 6 months. And as a consequence, it's a wonderful, wonderful movie that you might want to sponsor or show, Power to Heal. And within 5 months,
Without computers.
Without computers, they enrolled 16 million people and segregated hospitals in the South. No longer had black and white entrances, no longer had a overtly segregated situation. But that had to do with, I think, the rapid implementation of the program. Well, you've all been very generous, staying so late and asking really great questions. So keep doing that, and hopefully, you know, we'll be able to say in the next period that we have actually got something